The goals are to minimize risk of maternal CVA, but does not necessarily reduce the risk of seizures or prevent IUGR. To maximize maternal condition for safe delivery. To gain time for further assessment. Prolong gestation where appropriate or feasible. Anti-hypertensive drugs should be used if the diastolic blood pressure remains at greater than or equals to 110 mmHg after an hour of bed rest and anticonvulsive treatment. The goal is to keep the diastolic blood pressure 90 to 100 mmHg. That means less than 110 mmHg in labor. Management of with antihypertensive drugs. The use of antihypertensive drugs to control mild preeclampsia does not alter the course of the disease or may not diminish perinatal morbidity or mortality and should be avoided. Sodium restriction below the recommended daily intake and diuretics have no role in routine therapy. The choice of drug depends on the acuity and the severity of hypertension and whether or not parenteral or oral therapy is used. Acute therapy, labetalol and hydralazine are the best options for first-line therapy. Labetalol, first-line drug. Begin with 20 mg IV over 2 minutes, followed at 10 minutes intervals by dose of 20 up to 80 mg. Maximum dose of 300 mg. Example, give 20 mg, 40 mg, 80 mg, 80 mg, then 80 mg. A constant infusion of 1 to 2 mg per minute can be used. The fall in blood pressure begins within 5 to 10 minutes and lasts from 3 to 6 hours. It should be used in patients with relevant comorbidities, example, coronary artery disease. Hydralazine begin with 5 mg IV over 1 to 2 minutes. If the blood pressure goal is not achieved within 20 minutes, give a 5 to 10 mg bolus depending upon the initial response. The maximum bolus dose is 20 mg. If a total dose of 30 mg does not achieve optimal blood pressure control, another agent should be used. The fall in blood pressure begins within 10 to 30 minutes and lasts from 2 to 4 hours. Calcium channel blockers. Nifedipine with rapid onset of action. If regular capsule used, that means relaxes vascular smooth muscle, 5 to 10 mg sublingually as initial dose, followed by 5 to 10 mg if response is inadequate within 30 minutes. Then continuous 10 to 20 mg per oral every 6 hours. For maintenance therapy, 10 to 40 mg per oral BID. Methyldopa is the drug of choice for maintenance therapy. It has a minimal side effect and safe. There is some concern regarding ability to control blood pressure. Additional drug may be needed. Dosage 500 to 3000 mg per oral in 2 to 4 divided dose per 24 hours. Delivery. The definitive treatment of preeclampsia is delivery to prevent development of maternal or fetal complications. from this progression. Whether or not to deliver the fetus is based upon gestational age, the severity of preeclampsia, and maternal and fetal condition. Management. Mild or severe preeclampsia at or near term should be delivered. However, remote from term, the risk of serious sequelae from this progression need to be weighed against the risk of preterm birth. Evidence of serious maternal end organ dysfunction or non-reassuring tests of fetal well-being are indication for prompt delivery at any gestational age. Note: be careful. Delivery should occur within 24 hours of the onset of the symptoms in severe preeclampsia and within 12 hours of the onset of convulsions in eclampsia. Stable mother and fetus. A conservative approach is reasonable in order to achieve further fetal growth and maturity. Aggressive lowering of maternal blood pressure significantly impaired fetal weight. A 10 mmHg fall in mean arterial pressure is associated with a 176 gram decrease in birth weight. Corticosteroids used for 48 hours to facilitate fetal lung maturity, but only if conditions permit delay. Betamethasone 12 mg IM every 24 hours, total of 2 doses. Dexamethasone 6 mg IM every 12 hours, total of 4 doses. Indication for delivery. 1. Pregnancy at greater than 37 weeks gestational age with PIH, even if mild. Note that PIH is a progressive disease and sometimes is unpredictable. If cervix is favorable, do ARM and induce with oxytocin. However, if the cervix is unfavorable, ripen the cervix. Second, severe preeclampsia remote from term, less than or equals to 28 or 30 weeks gestational age. 3. Gestational age from 32 to 34 weeks with severe preeclampsia not responding to initial observation and treatment. Example: diastolic blood pressure greater than or equals to 110 mmHg despite anti-hypertensive medication. Indication for delivery. 4. Gestational age less than 34 weeks with any of the following or urgent delivery within 12 to 24 hours is in most cases is indicated. Severe hypertension not responding to treatment. Symptoms unresponsive to appropriate therapy. Suspected fetal compromise, eclampsia or convulsions. Lab evidence of end organ involvement despite good blood pressure control. Decreasing platelets or increasing liver function enzymes. With the exception of fetal growth restriction, any of these adverse events can occur suddenly in a woman with severe disease. However, if proteinuria greater than or equals to 5 grams is the only criteria for severe disease, because the amount of proteinuria has no correlation with risk of adverse maternal perinatal outcome. Similarly, if the only criteria for severe disease is mild fetal growth restriction with reassuring Doppler velocimetry or severe hypertension, then a conservative approach may be considered. Remote from term. Delivery. Second stage should be shortened by episiotomy and a low forceps or craniotomy with dead baby in severe cases. Avoid difficult vaginal delivery. Prevent the PPH. Manage third stage actively using oxytocin. Watch closely for at least 2 hours after delivery for complications such as shock, PPH, and eclampsia. Neonatal care is needed for premature and those with IUGR for respiratory distress. Route of delivery depends on gestational age, fetal condition, presentation, cervical condition, and maternal condition. Vaginal delivery is preferable to cesarean section for women with preeclampsia even if with severe disease. Avoid the added stress of surgery and anesthesia because of multiple psychological abnormalities. Aim for VX delivery, vaginal delivery by induction using ARM and oxytocin are needed under the following condition. If the cervix is ripened, if the fetus is dead or extremely premature for survival, with rapid progress in labor after cervical ripening under appropriate route of delivery. As trial of induction warranted because even though the cervix may feel unfavorable, labor can be induced and progress fairly. Cesarean section, if not begin within 6 to 12 hours, or if poor progress. C/S is reasonable for severe preeclampsia who are under 30 weeks of gestation and have a low Bishop score with NRFHRP. Only about 1/3 of preterm inductions result in vaginal birth. NB. Eclampsia is not a contraindication to such trial of induction. Cesarean delivery is indicated if the cervix is unfavorable, especially in seriously ill patients with poor progress of labor. If patient has not entered active labor within 8 hours of induction, if there is evidence of NRFHR or other obstetric indication, use of anesthesia. Do not use local anesthesia or ketamine in women with preeclampsia or eclampsia. General anesthesia with thiopental, succinyl cholines, and nitrous oxide is preferable. Regional anesthesia can be used with adequate IV fluid to reduce the risk of hypotension, except in patient mild preeclampsia. The optimum management for women with mild preeclampsia and stable maternal and fetal conditions at 34.0/7 to 36.6/7 weeks needs expectant management to enable further fetal growth and maturation. For patients managed expectantly, delivery is indicated as soon as they develop sign and symptom of severe preeclampsia or eclampsia, or at 37 weeks of gestation if the disease does not progress to this stage. Expectant antepartum management of mild preeclampsia. Inpatient versus outpatient care. Close maternal monitoring up on diagnosis of preeclampsia. Hospitalization is useful for making these assessments and facilitates rapid intervention in the event of rapid progression. After the initial diagnostic evaluation, outpatient care is a cost-effective option for women with stable mild preeclampsia. Outpatient care can be provided in the patient home patient's home or at antenatal day care unit. Patient offered outpatient monitoring should be able to comply with frequent maternal and fetal evaluations every 1 to 3 days and should have ready access to medical care. Management. Restricted activity is typically recommended since blood pressure is lower in rested patients. Rest in the left lateral decubitus position can augment utero-placental flow, which may benefit some pregnancies. If signs or symptoms of this progression are noted, hospitalization for more intensive monitoring and possible delivery is indicated. Assessment of fetal well-being. Daily fetal movement counts and twice weekly fetal non-stress testing with assessment of amniotic fluid volume or twice weekly biophysical profiles. Testing is repeated immediately if there is an abrupt change in maternal condition. Assessment of fetal growth. Early IUGR is a criterion of severe disease. Sonographic estimation for assessment IUGR and oligohydramnios at the time of diagnosis of preeclampsia and then repeated every 3 weeks if the initial examination is normal. Eclampsia. Eclampsia is the development of grand mal seizures in a woman with preeclampsia in the absence of other neurologic conditions that could account for the seizure. In 60% of the case, hypertension may be absent and proteinuria may be absent in 14%. Incidence 0.2 up to 0.5% of patients with preeclampsia. Onset antepartum 50%, intrapartum 30%, and postpartum 20%. Management of eclampsia. Management of eclampsia is symptomatic and consists of 6 aspects. 1. General measures. 2. Control of convulsions to stop ongoing convulsion and prevent repeated convulsion. 3. Correction of hypoxia and acidosis by clearing airway and giving oxygen by mask at 6 L per minute. 4. Control hypertension or BP and stabilization of the condition of the mother and fetus. 5. Fluid balance and diuresis. 1. General measures in the management of eclampsia. Shout for help. Position the patient on her side, left lateral, and in Trendelenburg or head down to reduce risk of aspiration of secretions. Aspirate or suction the mouth and the throat as necessary and ensure open airway. Give oxygen by mask at 6 liters per minute. Secure IV line. Catheterize to monitor urine output and urine test for protein. Monitor vital signs, fetal heartbeat, reflex frequently, and auscultate the lung base hourly for crepitation, indicating pulmonary edema or aspiration pneumonia. If the pulmonary edema occurs, withhold fluids and administer a diuretic such as furosemide for 40 mg IV. Stat. The patient has to be kept in the eclampsia room, a specially designed quiet room with intensive care unit or ICU. Management of eclampsia. Second, anticonvulsant therapy. Administer anticonvulsant drug to stop the ongoing convulsion and prevent the repeated attacks. Be aggressive and avoid under treatment to be successful. Magnesium disulfate is the drug of choice in eclampsia. Dose and duration is the same as that of preeclampsia. Delivery should take place as soon as the woman's condition has stabilized, regardless of gestational age, within 12 hours of the onset. Eclamptic usually proceed to labor spontaneously while having convulsions. If vaginal delivery is not anticipated within 12 hours, see cesarean section. Postpartum care. Anticonvulsive therapy should be maintained for 24 hours after delivery or the last convulsion, whichever occurs last. Continue antihypertensive therapy as long as the diastolic blood pressure is greater than or equals to 110 mmHg. Continue to monitor urine output and check for coagulation. Provide organ function test. In women treated with antihypertensive drug, antenatal continue antihypertensive treatment in postpartum and if severe postpartum hypertension. Treatment of complication. 1. DIC. Minimize trauma. Transfuse with fresh whole blood or fresh frozen plasma. Second, acute renal failure. Persistent oliguria for greater than 48 hours after delivery despite adequate fluid and diuretics. Restrict fluid intake to 500 ml plus ongoing loss. Third, pulmonary edema. Keep improper in up position. Keep improper up position. Give oxygen 100%. Restrict fluid intake 2.5 liter per day. Give furosemide 40 to 100 mg IV and aminophylline 480 mg IV slowly. Postpartum hypertension. Due to persistence of antepartum or intrapartum hypertension or may be of new onset. Pre-eclampsia related hypertension usually resolves spontaneously within a few weeks. Average 16 to plus or minus 9.5 days and is almost always gone by 12 weeks postpartum. Hypertension that persists beyond this period should be evaluated and treated as in any non-pregnant woman. Management. Antihypertensive agents may be required temporarily postpartum if hypertension is severe. Oral medication similar to those used in the non-pregnant population can be prescribed with modifications of the woman is breastfeeding. Furosemide 20 mg orally once or twice per day for 5 days may facilitate return to normal tension in women with severe but not mild preeclampsia, particularly those with significant edema. Prevention. Suggested prevention strategies. Calcium supplementation during pregnancy. In areas where dietary calcium intake is low, calcium supplementation during pregnancy 1.5 to 2 gram elemental calcium per day is recommended for the prevention of preeclampsia in all women, but especially in those at high risk. Risk reduction is 41% for women at low risk and 78% for high risk. Antiplatelet low dose acetyl salicylic acid or aspirin 75 mg per day is recommended for the prevention of preeclampsia in women at high risk of developing the condition initiated before 20 weeks of pregnancy.